So this is a 1.5 exchange. Can you open that up, Anand? But you can see a cemented cup, polyethylene or screws through the polyethylene cup, constrained liner, cemented stem, well fixed, Gherke 125, because Thorsten taught me 125 is good enough. Okay, next. You can see this is what I do with acute cementless hips. You debride the canal, do the lavage like Alberto. You put the beads down distal, so you have antibiotic canal beads delivering vancomycin or tobramycin or whatever you want, because I believe strongly that the organisms stay within the canal. And then if you want to use, the literature is replete that cemented stems decrease, with antibiotics, decrease the reinfection rate. So this is my way to do it with a cementless stem. You coat it on the stem, and then you insert that in. Next slide. And you can see this is a reimplant. You can do this with either acute infection or a reimplant procedure where you add the antibiotic beads. The beads are distal. They're on the stem, just like a cemented stem. And if you open up that slide, our paper was accepted in press that our infection rate with a cementless stem with this technique is similar to a cemented stem.
May I have one question, Ed? Are you not worrying about osseointegration? I mean, if you cover the uncemented stem with some kind of sulfate?
So we have 105 stems. There is no loosening. Blasted stems as well as porous coated stems, osseointegration was not a problem. Remember, calcium sulfate was a weak bone graft substitute. In theory, it should not inhibit osseointegration.
I just wanted to also say we did a basic science study looking at mice. When we actually pour the betadine peroxide down the canal and then we ended up putting cementless implant, they still grew in.
Yes,
So
I do that exact same technique.
So it doesn't seem to impair integration as far as we know. Of course, you have to get
Plus
good
the other thing,
rejuvenation.
I still believe that a reimplant or an acute, power reaming that bone where the organisms tend to go into that osteobone and you get rid of it, I think is good. And then if you do that, you don't have enough interdigitation of the cement for the long term. So that's why I think a spline tapered stem is a better way to go.
Let's go back to Christoph. We have 15 minutes more, including the questions, Parag. Thank you. So due to the fact that we couldn't identify the bacteria, we went for 1.5 or two-stage exchange. Let's talk a little bit about spacers. What kind of spacer type do you prefer, Alberto?
So my ideal spacer involves some sort of acetabular. I don't necessarily like using a ball that articulates against native bone. I like the idea of being able to cement in a liner. There is one on the market which has a semi-constrained mechanism. Very nice, very flexible. On the femur, having something where I have to do some sort of femoral preparation, and I can then input an implant that has some axial and rotational stability like Amar said.
Vijay.
Two-stage, we will do always a non-articulated spacer, so separate one in the socket, one in the femur. There are no complications for that, and bringing down the hip has never been a problem for me.
Dan.
Yeah, for the simple ones, we use a articulated spacer with a polyethylene semi-constrained socket that's cemented in place, and then a stem that's coated with cement except for the femoral head, and we add cement to make it stable, to Ed's point. For patients that have super high risk with spacers, and there are some, patients at high risk for instability, patients high risk for fracture, I will personally do a non-articulated spacer.
Yeah, well, for simple patients, a preformed spacer, but most patients usually get a nail which is impregnated with cement on the femur side and a blob of cement on the sternum, and a non-articulating one.
Ed, we have seen what you are doing, and Guvara?
I take the smallest bipolar and coat it with the cement.
Okay. So this is our spacer, which is very similar to Dan's spacer. A stem, a cheap cemented stem, implanted in a bad cementing technique to get it out easily, Amar, and we use as a liner the semi-constrained, the double mobility liner. So the question is, you are doing now, you put in a spacer, and then can you go through this list here? How long, let's say length of the interval, length of antibiotic therapy, do you do antibiotic holiday and reaspirate before implantation? Very quickly, Govar.
6 weeks of antibiotics, 2 weeks of holiday, no aspiration before reimplantation.
4 weeks of antibiotics, 3 aspirations, and when they're ready financially and family is ready, then the reimplant.
Around 2 months of antibiotics and at least 3 months of spacer being there, and a holiday of around 2 to 4 weeks.
6 weeks of high-dose antibiotics, typically about a 6-week holiday, not for the sake of the holiday, but rather just to let the wound keep quieting down. And then typically at 12 weeks, we come back and reimplant, roughly.
6 weeks of antibiotic therapy, 2 weeks of holiday, and if the parameters tend to stay low, no reaspiration, but if they reverse, aspiration.
I should have said that too. We don't reaspirate unless there's something funny with the parameters.
No reaspiration.
6 weeks antibiotics, 2-week holiday, aspiration, and then waiting for cultures for 14 days. If there's a fungus, all those numbers are tripled.
And now I'm really keen to hear the opinion of a specialist, because does it make sense to have an antibiotic holiday first, and does it make sense to reaspirate from your point of view?
Well, I'll tell you, I mean, in practice, we do exactly what Alberto just went through. The literature I know does not really, require the need for an antibiotic holiday or a reaspiration. And there are a number of surgeons I work with who we do not reaspirate or have an antibiotic holiday. It's, but again, we have with 30, 35 surgeons, practice patterns vary. But when I was sort of growing up as an ID doctor, I was very afraid of not doing the holiday and not doing the reaspiration. But just in seeing it over the decade, decade and a half, the yield of positive on a reaspiration in someone who's recovered well and healed well is infinitesimally small. And I think the reason for waiting actually is more important, is to make sure you have a good, the soft tissue is healed. I think that's the more important part before going back for the second
Okay,
stage.
more the clinical side than the microbiological. And I agree, it's very, very difficult to conduct 35 very high-performing surgeons. So 2 months later, everything was okay with Christoph, and now we are coming to the reimplantation. Dr. Kumar, here's the X-ray. What would you reimplant? What kind of implants?
Yeah, it would be a cementless reimplantation, both sides. And I would go for the shortest stem, which gives me stability. A 190 mm Wagner would be fine on the femur side. Not more than that. I think that would take care. And I think there's not much bone loss on the vestibular side. Also, a standard cup would do.
Okay, quick answer, Vijay. Quick answer.
The same actually, yeah. Non-cemented on both sides.
Uncemented both sides. Who would cement something? Nobody. Uncemented both sides. I think that's a great recommendation. Here you see the X-ray of my case here. And I use, Amara, excuse me, always a dual mobility cup, because due to the debridement during the 2 procedures, so the soft tissue is a little bit weak, just to ensure that everything is okay. And Christoph played tennis again after 4 or 6 months, so he is quite active again.